Welcome. Thank you so much for joining us today live or on the recording for episode 27 of Dr. Jeff Talks About Sex and Intimacy, Understanding Peyronie's Disease, Causes, Treatments, and Hope. You know, it means so much to me that you took time out of your busy day to join us. So I really, really appreciate you being here to learn more about this subject. We are on social media. We're out there on Facebook. We're on YouTube. Wherever you are, we are. X, Linked, and Kick. We're out there. If you're on X and you have a question, please go to YouTube or LinkedIn or Facebook or one of the other sites or StreamYard to allow you to send us those questions. If you are on Facebook and you're a follower, please follow us. And the more followers we have, the more we'll be able to do on Facebook. We're already on there, but we'll be able to do even more. So thank you. Go to the website. There's so many excellent episodes with great guests. Please go to the website to find those past episodes. There's quite a few of them in there. You can go to the calendar and see what's coming up next. And all that information is on the website. Listen to us in your car, wherever you are, on your favorite streaming service like Spotify, iHeartRadio, Amazon Music, whatever your favorite is. If you're in the gym working out, if you're in the car, we're there with you. I want to remind you all that all are welcome here. All are welcome here. You are most welcome here. And we're so glad that you're here with me today. So, realize that you are very welcome here. Whatever your sexual orientation, your gender identity, or your relationship style, you are most welcome here. Now, the goal of the podcast, it's really simple. It is just to empower and enlighten you with the information you need, the scientific evidence-based information you need to improve your sexual health, to deepen your relationship with that loved ones, helping you to live and love more fully. Today's episode, thank you for your patience. We wanted to make sure we had the presentation fully loaded, and we're really happy to have this episode today. It's about a condition that affects many, many men, but is still not widely understood and often not openly discussed and stigmatized: Peyronie's disease. This condition, which involves the development of scar tissue inside the penis and can lead to pain, curvature, and/or challenges with sexual function. But there's hope, and there's effective treatment options. To help us better understand the causes, the symptoms, and the latest treatment strategies, I'm honored to welcome one of the foremost experts, and I mean, he is one of the experts that really knows everything there is to know about this field, and that is Dr. Laurence Levine. His expertise, compassionate care, and groundbreaking research have helped countless individuals and couples to navigate this often distressing diagnosis with both confidence and dignity. So Dr. Laurence Levine is a world-renowned urologist, researcher, and professor of urology at Rush University Medical Center here in Chicago, where I am. He's an internationally recognized expert in male sexual dysfunction with special focus on Peyronie's disease and erectile dysfunction. Dr. Levine has authored over 200 peer-reviewed publications and book chapters and has been a principal investigator on countless clinical trials related to men's sexual health. He played a pivotal role in the development of the first FDA-approved non-surgical treatment for Peyronie's disease and has educated both medical professionals and patients globally on this condition. Known for his compassionate, patient-centered approach, Dr. Levine is a sought-after speaker and clinician who has helped countless men improve their quality of life and intimate relationships. I am honored to have Dr. Levine. Thank you so much for taking time out of your busy schedule to join me. I can't think of anybody better to help us understand this topic. I think the audience is in for a real treat with learning from your expertise this evening.
Thank you very much, Jeff. I'll tell you, it's an honor to be with you, and we've known each other for many years now, and I just shout out to you and just say what an incredible person you've been in this field, consistent, always giving, always trying to share and expand knowledge in the field of sexual medicine. It's when you asked me to participate in this, I could say, of course, was yes, because whatever you do is good, and I'm hoping that what we do tonight will be successful, both for those who are listening now and maybe in the future on recorded product that we have. So thanks again.
Absolutely. Oh, thank you. I'm so thrilled to have you here. And lots of folks tend to watch the recording later. Sometimes we've looked at the recordings for the next day, and there's like 2,000 hits already on the different pieces of the recording. So people are definitely interested in these topics. Without further ado, I'm going to hand it all over to you and your presentation.
All right. Well, again, thanks again for allowing me to participate in this. I have been involved in the field of Peyronie's disease probably for the part of 30, 35 years. It all started many years ago when I was a young attending at University of Chicago, and I came up with an idea for a new treatment option for Peyronie's. That sort of launched me into this field in a big way. So I've got a trimmed down talk. If you would ask me to talk for 3 hours, I could do that on Peyronie's disease, but we'll keep it to about 25, 30 minutes, and hopefully it will give you all information that could be useful. Some of it is maybe directed towards medical type professionals, but I've tried to keep it so that the lay public would be able to understand what we're doing here. If there's issues with that you don't understand or need further information about it, please feel free to contact me. My email, just so is dr as in Dr. Levine at hotmail.com. So we'll just get with the first slide. So this is probably one of the most important slides that we can share. That is that Peyronie's disease is both a physically and psychologically devastating disorder to the affected man. A lot of people think of it as really just a deformity of the penis, but we can imagine what that does to a man in terms of what they care about. And as I talk to my patients every day about Peyronie's disease, I think men care about two things: their brain and their penis. And if things are going wrong with the penis, this can cause some serious psychological distress. It is also not a rare disorder, as previously thought, where up to 10% of men can be affected. And it does not tend to resolve spontaneously, also as previously thought. Many studies have shown that probably less than 10% of men have Peyronie's disease that resolved spontaneously. Frankly, I don't think they had Peyronie's disease at all. They probably had a scar. It just simply took some time to resolve. But in the first year, when men develop this disorder, studies have shown that up to 50% will get worse from the time they come to see a doctor, but the remaining population stay about the same. There is no non-surgical cure for Peyronie's. There are a lot of different treatments out there that we're going to go through tonight quickly, but I do think that some of these non-surgical treatments can stabilize the disease and prevent progression, because as I said before, 50% can get worse if we do nothing at all, and maybe even decrease the deformity and make them more functional. We should realize that we're dealing with scar tissue here, and change with Peyronie's disease occurs at glacial speed. So scar changes very slowly. It can result in very quick changes in the penis when it's becoming active, but to get it to resolve, that happens very slowly. And I think we should also know right up front that surgery is the most rapid and reliable treatment. It is what we would call the gold standard. But there are other treatments that may be of some benefit and can help, and we'll discuss that. And diagnosis is easy, I think, for the practicing physician, but treatment remains a treatment challenge. Next slide, please. So when we talk about pathogenesis, what do we understand about what causes this? The current understanding is that Peyronie's disease is what we call wound healing disorder, which occurs, we believe, in a genetically susceptible individual whose TA, that's allogenea. That's the jacket tissue that surrounds the vascular tissue that fills with blood in the penis. That vascular tissue, that A, responds inappropriately to an inciting event. That might be trauma, an injury to the penis. And that response results in a proliferative fibrotic or scarring reaction, resulting in this exuberant, inelastic scar. And probably the most important point here is that it does not resolve. In the normal situation, when we build up a scar, at some point the body sort of recognizes that's enough scar, and remodeling occurs, and the scar dissipates and it goes away. But not with Peyronie's disease. The scar remains, and if you wait till the cows come home, the scar will still be there. Next slide. So how do we evaluate that? Go to the doctor. They'll want to know, when did it start to occur? Because this gives us a sense as to whether we're in the acute phase, which is long as the first year from onset, versus the chronic phase where it tends to remain stable. As I said, believe trauma activates this process, but only 20 to 30% of my patients, and I see 20 to 30 men a week with this problem, only 20, 30% recall an event where they may have injured the penis. So why would trauma be a cause? Well, imagine the penis in the erect state. It has pressure within it, and during intercourse, if one partner goes one way, the other goes the other way, this can put significant pressure on the penis that can result in extremely high levels of pressure within the penis that can result in a microfracture. It might be a oh kind of moment, and the man will adjust and carry on because they're having fun, but they won't think about it for another moment. But that process can activate this unusual scarring process. Pain can be associated with this problem. Oftentimes in the early phase, it's called inflammatory pain. I'd like to know what the patient estimates their curve to be, and I ask about length loss, as men have reported up to 4 inches of length loss. Certainly 1 to 2 inches is quite common and devastating. I like to understand how the men would regard their own erectile hardness on a 0 to 10 scale, 0 being no erection, 10 like they were 25, to get the idea there. And they engage in penetrative sex in spite of the deformity they have. It's amazing. Where there's a will, there's a way, but it may still be compromised in terms of the ability to engage in all sexual activity that they may be interested in. And lastly, we want to know about risk factors for erectile dysfunction. Diabetes, high blood pressure, cholesterol, and smoking certainly increase the risk of ED, which can certainly exacerbate the Peyronie situation. Next slide. On exam, we want to grasp the penis. I have some pictures here, so hopefully they won't be offending anybody. But we want to grasp the penis and place the penis on stretch. This amplifies our ability to identify the scar. Then, very important, you want the doctor to measure the stretch length of the penis, and we measure from the pubic bone to the beginning of the head, because these are 2 fixed points, and we want to make sure that they haven't changed much over time. I always get what's called a penile duplex ultrasound. This is a test we do right in the office. This is to assess for calcification, because a different genetic subtype of Peyronie will develop actually bone within their scar. I've had men with bone that big in their scar, but oftentimes it's just little stippled calcification, little dots of calcification. Either way, about 1/3 of men will develop this calcification, and it's the ones that are very big that are the problem. We do a variety of other measurements during this study, but probably most importantly, it allows us to really see and measure the curvature and or indentation during the development of an erection during the duplex ultrasound, because you're given an injection into the penis to induce an erection, hopefully to be as good as what you have at home. Next slide. So here is measuring the penis on stretch. You can see the penis is being grasped by the head, gently being stretched, and then we feel on the shaft. The plaques are, we call these scars a plaque. It's an old term for scar. They're always anchored to the top of the septum or the bottom of the septum. And that's important for the surgeon to know, because that is something we want to address during any type of surgical procedure for sure. Next slide. We then measure the strap length, and as you can see, I'm pushing down on the skin at the base of the penis and measuring up to the beginning of the head. We call that the corona. Next slide. And then after the injection, we induce the erection and measure the curvature with what's called a goniometer. It's kind of a fancy protractor, but it allows us to assess what the curvature is. And, there's a lot of controversy as to the best ways to do it. Should it be done with a photograph? The problem here is that it's a two-dimensional image of a 3D problem, and curvatures are not necessarily always just one plane. They can be multiplanar, as we'll talk about in a moment. Next slide. Here is a gentleman with a severe curve. As you can see, it's almost 90 degrees, parallel to the plane of his body. Next slide. But he also had some narrowing in the shaft, and you can see how it hinges just by placing some very light pressure on the head of the penis. The penis will fold over, and we call this a hinge effect, which adds another degree of complexity to this problem. Next. And here's a rather severe curve where you have severe deformity, where you have severe curve, you have indentation, you can see in the mid shaft where it narrows down. We have hinging, and we have torsion. There's a twisting of the shaft as well. So this is the variety of presentations are extreme. Another to follow. Next slide. We call this the turkey leg. You can see there isn't much curvature, but it's narrow at the proximal half of the penis. But go out further out towards the head, you can see it widens out to the more normal caliber of the shaft. And lastly, and next, is what I call the Bordeaux bottle. The French wine Bordeaux kind of comes up as a nice uniform caliber, and narrows down at the neck, and that's what we have here. Again, this makes it for a complicated situation because he does not have curvature, but he's narrowing because the scar tissue is wrapping around the shaft and preventing expansion in that area. And I should just say at this time, how does this all occur? The scar tissue is like a piece of tape on a balloon. If you take a long, skinny clown's balloon, you blow it up, it expands in girth and length in a very uniform fashion. But if you put some tape on top of the balloon before you blow it up, and then blow it up, you curl upward and make it, an upward curvature. And if you put the tape around the balloon, depending upon where you'll get hourglass deformity, or you can get something like this Bordeaux bottle. Next slide. We did a little review in my practice over the last 5 years. You can see I see an awful lot of patients. We had over 1,200 patients seen with Peyronie's disease who had inclusion criteria. And the average age was 55 years, but you can see there were men as young as 18 to as old as 83 presenting with new onset Peyronie's disease. So it can happen in a broad number of patients in terms of age. Patients oftentimes waited to come see me. My practice is national, so I have people all over the country, and maybe up to 2 or 3 years before they end up on my doorstep. And the primary curvature, as we called it, average curvature was 50 degrees. That's a pretty nasty curve. But the range was 5, very little curvature because they had indentation, or very severe, 120 degrees. The worst I've ever seen was 150-degree curve. Next slide. Also in this study, we found that the least common curvature was downward bend. We call that a ventral curve, but they can be multiplanar. A third of patients were up and lateral or down and lateral. And we found on those ultrasound studies that indentation, or hourglass deformity types of irregularities, occurred in up to two-thirds of patients, three-quarters of patients. So it is previously thought that indentation was a relatively uncommon problem. In fact, it is quite common in the man with Peyronie's disease. And we looked at surgery. In spite of the fact of my being a very much surgery-oriented center. Only a third of patients ended up undergoing surgery, and there's a variety of surgeries that would be performed, which we can talk about later. But the predictors of needing surgery pertain to the severity of their curve, whether they had an hourglass deformity with a hinge, and whether they had previous exposure to a drug called Xiaflex, which we'll talk about in a slide or two. Next slide. So who are the candidates for non-surgical therapy? Well, that would be patients who have early phase disease. That means less than 12 months since the onset. They have unstable or progressive deformity of plaque. They have painful erections due to inflammation that has not yet resolved. But most importantly, be those patients who are not psychologically ready or interested in surgery, regardless of the severity or duration of their disease. If patients tolerate the idea of surgery, non-surgical treatment is certainly an option. Next. So here's the beginning of a list of non-surgical treatment that's been offered since the time of this Dr. de la Peyronie, who was a physician in Montpellier, France. As you can see, top line there, he used mercury, poison, and this mineral water from the Pyrenees Mountains near where his medical school and practice was. And if you go down this list, you can see all kinds of horrible things. You can see bromides and arsenic and radium, crazy stuff that's been used because we really don't understand. Slide. And the list goes on. With all kinds of treatments being offered to try to either stabilize or correct the disease. Next slide. But if we look at what's available in the contemporary practice of medicine, very few trials have been done which have been well controlled and designed to really give us information about what works and what doesn't. What we can tell you is that a lot of the things that are frequently used don't work. So do not use vitamin E, Potaba, colchicine, tamoxifen, carnitine, or omega-3 fatty acids. These have all been looked in properly done studies. They don't work. So don't waste your time, don't waste your money or your energy on using them. A couple things that I do use because they make scientific sense, although there's not a lot of evidence to show significant benefit, but they do make sense and they're non-toxic and inexpensive. One is this drug called pentoxifylline, and the other are a group of amino acids like arginine, citrulline, carnitine, and even drugs like Viagra and Cialis have beneficial anti-scarring, we use the word anti-fibrotic, anti-scarring effects. So they can be used as part of the treatment, particularly in the early phase of Peyronie's disease. Next slide. Injection therapy has been used historically. Back in the 50s, it was thought that injecting a steroid into a scar was going to help. The problem is the studies were very poorly done, no evidence of real benefit recorded. And there are certainly some negative things that can happen with steroids. So I do not recommend steroids at all. Verapamil was the drug I introduced back in the early 1990s. That's what kind of put me on the map as an expert in Peyronie's and kind of stuck with it since that time. It still does make scientific sense. We're injecting this drug, which affects the cells which make the scar. These cells are called fibroblasts. They're all over our body. They're important cells, but they're in a sense out of control in the man with Peyronie's disease, in the penis only. And we have found that if we inject this verapamil, we can oftentimes stabilize, stop progression, and maybe get improvement in up to 60% of men in terms of reduced deformity. Interferon was offered some years ago, but is no longer available. But the most recent drug is this drug collagenase, which is also known as Xiaflex. And this is, in essence, a chemical knife. We're injecting this enzyme directly into the scar tissue to dissolve or break down, let's say, the scar tissue. And it was approved in 2013, and it remains as the only FDA-approved non-surgical treatment for Peyronie's disease. Next slide. But there are problems with XIAFLEX. Most of the studies, or a lot of the patients I see, have not been properly evaluated to see whether they really are good candidates. If they have extensive calcification, it doesn't work because the calcification has replaced the scar tissue. If they have a minor curvature, I saw a young man today, actually he's 20 years old, who was thought to have Peyronie's. He did not have Peyronie's, had a congenital curvature. And they were injecting XIAFLEX into this young man with some duress. It made no sense. But people, doctors say, hey, look, maybe we can try this and maybe it will work. And unfortunately, it did not. And it's very expensive. As you can see, it's about $6,000 per shot, usually covered by insurance, either partly or in full. But it does require multiple visits. And as you can see here, it does not correct length loss, narrowing, hinge, or D. It really is just trying to work on curvature, try to reduce the tethering of that scar tissue. There can be hematoma, black and blue, which can be quite extensive, and rupture of the tissue has also been reported, but that's only 2%, but nobody wants to be in that 1% to 2%. I think the most important thing here is that with all of this, including the rather high expense, there is a low likelihood of near to complete curve correction. Now, some men, they say, hey, Doc Levine, I love you. I think you're great. You're an expert in the field, but you're not touching me with a 10-foot pole, never mind a knife. So let's do XIAFLEX first. And of course, we can do that. Whether it makes sense or not is another issue. And we'll talk about that a bit more in a moment. Next slide. Here are some of the originally published studies looking at results. At the bottom line in the yellow, you can see the mean range of curve improvement. The lowest one was my own data. We had our first 4 or 5 patients from back in the 2014-15 era, and we had an average curvature reduction of 5 degrees. I suggest to you that is within the realm of error, maybe not improvement at all, and if it is minuscule. But the bottom line, in the best of studies, we still didn't get much more than 20-degree reduction of curvature. And this is going to be important as we go through this talk. You'll find most of the non-surgical treatments don't offer much more than a 20-degree improvement. Next slide. A drug which I helped develop in a sense in terms of doing some studies to see if it had some benefit is a topical agent. I think everybody would like to be able to apply something topically or take a pill that would work. As we talked before, pills don't really have much evidence of benefit. Here is a topical treatment using emu oil, the bird, emu bird, that has a special oil within its skin that can be harvested and used in the cosmetic and in the medical industry to drive other drugs through the skin into the underlying tissue. And those drugs are called nicardipine and superoxide dismutase. This is a drug or a gel which is applied twice per day to the penis. And as you can see, at 6 months, we found an average curvature reduction of 20 degrees. Again, that 20-degree number is repeatable in virtually every study that we've looked at in terms of non-surgical treatment. Next. A lot of people come to me and they want to try the new best thing, regenerative therapy. What about platelet PRP or shockwaves or stem cells or amniotic factors? These are sort of the new wave of treatment of tissue. Why can't we just bring the tissue back to a more primitive state and have it start over again? With PRP being platelet-rich plasma. Well, studies have been done, and many of them published, and they showed no evidence of benefit with respect to reduced deformity. So for using that to try to reduce the deformity, it don't work. Next slide. Penile extenders were introduced about 15, 18 years ago. In fact, some of the early studies were done by my office, showing some benefit. And the principles are like putting brace on little Johnny's teeth. Little Johnny's got teeth like this. We're going to put the braces on, and slowly but surely, the teeth will move slowly within the bone of the jaw. And after 2 years' time, it always works. We get nice straight teeth. So why not use that same principle on the penis to try to stretch and encourage remodeling of tissue? And it has been shown to be effective. Next slide. The goal of traction therapy is to stop progression, so it doesn't get worse, recover length and girth, very important, reduce curvature. I have seen up to 40 degrees of curvature reduction, but that's when somebody is really using this a lot. Enhance their sexual function. And of course, if we can, avoid or simplify surgery. Next slide. But I think in my practice, I use what we call combination therapy, where we're trying to create what we call synergy. The addition of one and the other is better than each one alone. And that would be using the chemical effects of oral and injectable drugs, as well as the mechanical effects of external traction therapy, like we were just talking about. So the combination is probably a good idea, particularly in the acute phase. Next. Now, I was asked last year to go down to the country of Colombia for their annual meeting and talk about Peyronie's disease. So I kind of looked at published data going back over 20 years now to some of the early studies I did in the early 2000s on verapamil. And you can see we had verapamil and traction and vacuum devices and shockwave therapy and that gel I just spoke of and other forms of injection, including PRP, and the Xiaflex collagenase injection. And what do we see? Over on the right side, you can see the average curvature reduction of 18 degrees. So no matter what you throw at the penis, maybe, if you're lucky, you're going to get, in the average person, a 20-degree reduction of curvature, which if you've got a 30 or 40-degree curve, may be good. But the majority of patients I see are in excess of 50. I saw a patient today with an 80-degree curve, not uncommon. And so throwing these agents at that kind of curvature is unlikely to do much good. It may make it a little bit less, and that may feel better, but it's probably not going to make you truly functional again. Next slide. So that then brings us to surgery. If we get into the stable phase, and we have a painless deformity, and the patient is compromised in terms of their ability to engage in sexual activity, either because of the deformity and or they don't have good rigidity, and they failed conservative therapy if they wished, then I think the most rapid and reliable approach is surgery. Typically, these surgeries are outpatient. You go home the same day as the operation. They take 1 to 2 hours to perform, and they have a high degree of success in terms of correction of deformity. Next slide. We wrote the very first algorithm on how to address the patient with Peyronie's disease back in 1997. And so that's if you have this, then we do that kind of approach. And so in men who had good rigidity, with or without medications like Viagra or Cialis, we would do, number one, a tunic plication, which is a tuck of tissue, basically trying to shorten the longer side of the penis to correct the curvature. And that would be best if the curvature was less than 60 degrees and there was no narrowing or hourglass or instability. If they had more severe deformity, greater than 60 degrees, and or they had an hourglass deformity or hinge, then we recommended cutting out that little area of scar and placing graft. Next slide. Now, there are multiple different plication techniques. That's that I was about. So imagine here's the bent penis. There's 2 ways of straightening that. One would be to shorten this side to bring it up, or we can lengthen this side. That's the grafting procedure. We're going to talk about the shortening of this side to make it straight. And there's a variety of different approaches here. One that I prefer, the so-called modification of the Duckett-Baskin procedure, uses a partial incision with plication using absorbable suture. Again, outpatient procedure, I've probably done 1,000 of these operations with a very high rate of successful correction of deformity and a very low rate of causing new erectile dysfunction or sensory problems to the penis. Next. The principle again is that in this case, we have a downward curvature. We're showing these little areas that are cut and then closed, and that slowly, progressively corrects the downward curvature. There are variations again on how to do that. Next slide. So what are the drawbacks of doing application? Well, it does not correct shortening. So a lot of men are devastated by the shortening of the penis, and there's no reliable way to recover that, and you certainly could make it worse with application depending upon the severity of that curve. It also does not address hinge or hourglass, this plication approach, and there can be some pain or not, so sensory changes are possible, but again, using at least the way I do it, the modification I have, these are unlikely side effects. Next. The excision and grafting, we call it a PEG, P-E-G. The most important indication is strong preoperative erection. So I ask my patients while I'm working them up, tell me about the quality of your erection. If your penis was straight, would you be able to have sex? And if the answer is, oh yeah, no problem, I'd be able to, no issues whatsoever, well then they would be a candidate for the PEG procedure, the grafting procedure, if curvature was greater than 60 degrees, or they had narrowing with a hinge, or they had extensive plaque calcification. Next. So what are the advantages of doing the grafting? Well, I think it's the best opportunity to correct severe curvature. It is the only approach to reestablish girth and correct hinge. It's the least likely to cause length loss, and it's the most likely to enhance length without traction postoperatively. So we can actually recover some length, not covering inches, but we might get back a centimeter or two of length. Next. What are the risks of PEG? And I think this is important. Probably the most important risk would be diminished rigidity to complete erectile dysfunction. Luckily, that doesn't happen very often when the patients are properly selected. You could have incomplete correction of the curvature. There's shortening, which can happen with grafting. Again, that's rather rare. We just did a survey of our patients. Over 75% actually had gained length to some degree, somewhere around 1 to 1.5 centimeters. And you could have some temporary reduction of sexual sensation, which tends to recover with time. Next. The newest thing that we have, that's probably been in the last 5 years or so, is what we call extratunical grafting. Just did one of those this past Monday. And that would be if there was residual indentation deformity after we corrected the curve with the plication or with the graft. And this would be put in as a sort of a filler, get a more normal caliber to the shaft of the penis. So it's really more of a cosmetic treatment. It does not provide support. It just provides some girth. And a variety of grafts have been used historically. We now have some pretty good long-term follow-up showing good results. I think that was on our next slide. And this just shows a paper we published last year with 35 of these cases with a follow-up of 2 years or more. 94% of the patients were actually quite satisfied with the correction of their indentation. Some patients could actually see through the skin, the graft, it would kind of have an impression on the skin. But when they got an erection, it disappeared because the penis would fill out and become more uniform in caliber. But there were very few complications, no persistent pain, no contraction, we had one patient who had some persistent sensation issues, probably from the grafting procedure that had been done before, but nobody was bothered by the visibility or the palpability of the graft. Next. Finally, we have men who have inadequate rigidity, who have erectile dysfunction associated with their Peyronies. And we should understand that we take a population of men the same age with Peyronies versus a population without Peyronies. this population with Peyronie's have a much greater risk of developing ED over time, probably because the scar tissue interferes with the trapping of blood within the penis. Suffice it to say, if they present with Peyronie's and erectile dysfunction that does not respond to pills like Viagra and Cialis, then we would recommend placement of a penile implant. Sometimes the implant alone will straighten the penis out. Sometimes we have to do what we call modeling, stretching the scar tissue while you're asleep to, we call it crack the plaque. And sometimes if the deformity is severe enough, we have to do incisions and then place a graft over that area of where we've opened up the tissue. Next slide. So for that population who comes in with ED and Peyronie's disease, we want to assess the severity of their erectile dysfunction. So I have them try, if they haven't already, try Viagra or Cialis at maximum doses. And if they're still not responding, then the recommendation is move directly to a penile prosthesis. And we do that even in the acute phase, as this may prevent further worsening of the deformity, in particular, prevent further length loss. And we have found that actually there's no increased rate of infection or malfunction of these implants in patients with Peyronie's disease. Next. This was an interesting study we did some years ago. When I was a young surgeon, I was always told, geez, you know, if the patient's over 55 years old and has Peyronie's disease, put a penile implant in them. Well, you know, I'm well over 55. I'm well over 65. And I don't want an implant if my erections are good. So we looked to see if that algorithm that I had previously noted would be a guide. And we had 86 patients where we used that algorithm and found that 25 of them, we performed a tunic plication. 22 of them, we did leg operation, a much more complicated approach. Again, in older men, the average age was 68. And then 39 with prosthesis. And if you look at the area where it says penetrative sex postoperatively, anywhere from 92 to 95% were engaged in penetrative sexual activity after surgery. So it's all about patient selection. The patient has high quality, strong erections on their own with or without Viagra or Cialis type medications. They could have the operation without place of a penile implant. Next. So what do patients need to know? They need to know truth about Peyronie's. First of all, surgery has a 90% likelihood of making the penis functionally straight, which I define as 20 degrees in any direction. 20 degrees is certainly within the realm of normal. Nobody's going to be bothered by that. Xiaflex, the enzyme we were talking about, has a 70 to 80% chance of reducing the curve, but only by 20%, and maybe that's 20 degrees, and a very low likelihood, if they're over 50 degrees, of having a residual curvature of less than 30, which would be, again, hopefully within a range that would not interfere with sex. Therefore, when the patient is properly selected, surgery has a low risk of complete erectile dysfunction. And we should also recognize, again, that Xiaflex does not correct length loss, indentation, hinge, or ED. That's really more on the surgical side. Next slide. And last slide. So in conclusion, Peyronie's is a challenging scarring disorder. Absolutely is. There's fortunately no cure in sight because we don't really understand the process of why this scarring occurs and why it doesn't go away, or how to trigger, how to make it go away again in a reliable way. I do think that combination non-surgical treatment, especially in the acute phase, that first 6 months to a year after onset, makes sense, but it may not do much. It may only give you 10 to 30 degrees of curvature correction. Surgery does remain the gold standard. And I always tell my colleagues that you can't offer optimum therapy, you don't have the full menu of treatment options. Those patients should be referred to experts in the field. And I think for those who are interested in this field, particularly in the area of medicine, this is a wonderful opportunity for research because we still have a long way to go before we understand it. And my very last slide This is a picture of me with a portrait of Dr. Francois Gigot de la Peyronie, the doctor who described this in 1743. I was invited to speak at his lecture hall in Montpellier, France, back in 2016. I have a little bit of a sense of humor, so I dressed up like a 18th century doctor with the wig and the outfit there. Thankfully, got a couple laughs. I could have been booed off the stage, but they got the joke. And it was an honor, though, to be in his lecture hall and discuss Peyronie's disease as we understand it today. So I hope that this review, which was a lot, but as it's recorded, you can go back and review certain segments that might be useful to you. And again, I suggest that if you are have this problem and you want further information, you can certainly contact me or contact my office at Rush University Medical Center. Thank you very much.
Wow. Well, I think everybody can appreciate why I wanted you to come, and that I can't think of anybody else better to talk on this subject. I mean, you've done so much great work in this field. And honestly, I just look at your career in life, and as you said, we've known each other for a long time. We're both up there a bit. And but I will say, I just am in awe of all the work you've done with evaluation and treatment of these male sexual disorders, in particular Peyronie's disease and erectile dysfunction. You are such a source of excellence in terms of evaluation, treatment, but also the research that you've contributed, all the good things that you've done. Such important work. So thank you for dedicating your life really to helping men with these very private, very stigmatized issues.
True. Thank you for saying that. It's true.
It's a big deal. And we both know when people walk in our offices, right, Larry, nobody wants to really have to talk about all this. These are things that are really challenging for them, and they feel a lot of shame, a lot of really difficult things around this. So I think it's not easy for them to come in and be evaluated and really helped with these problems. So I commend all of the men out there who are brave and willing to really look at and address and improve their sex life through these different things. So if you're one of those men, you're not alone, that's for sure. We've got a couple of really good questions for you. So let's start with the first one. I thought this was a great one. They were asking, in particular, could you describe a little further, how are the PDE5 inhibitors used to treat Peyronie's in particular? We know they're used for erectile dysfunction, and we've talked before about that, but how are they used, and how do you think they help in this particular circumstance with this scarring process and all the things that are going on with Peyronie's?
Well, it helps in a couple ways. First of all, a lot of men, as I said, may have some associated erectile dysfunction. So just taking a PDE5 inhibitor may enhance their erectile response and make it so that they can have more successful sexual activity, particularly if the deformity doesn't interfere with sex, that they can work around it. But from a research standpoint, the PDE5 inhibitors, and I was speaking specifically of Viagra and Cialis, which have both been examined in the research sphere, have been shown to affect fibroblast activity. The fibroblasts are the cells which make the scar, and by giving this medication on a daily basis. And so typically what I'll do is, for instance, tadalafil, the generic of Cialis, or sildenafil, the generic of Viagra. I'll use the lowest dose that they typically manufacture. That'd be 5 milligrams of tadalafil or 20 milligrams of sildenafil daily. This can actually help with erections again, but may have beneficial effects in terms of slowing the scarring process. And I use that in concert with an amino acid complex, which actually can be obtained online. It's called Vitaflux, 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 and it can be obtained from the promescent.com website. Some of the Targets and some of the bigger pharmacy chains now are carrying it around the country. But again, urology.com is one of the websites you can get this VitaFlux. So those are the two type agents I would use orally as part of treatment for Peyronie's.
And like you said, it makes a lot of sense when you think about the fact that just improving the blood flow to the penis a little bit through these agents may improve healing through that as well. So it makes sense. And then its effect on the fibroblast activity. Excellent. All right. Next question was, I've noticed a bend in my penis, but no pain, no plaques, nothing else. Could it still be Peyronie's disease when I go from soft to hard? This person was saying, could that still be Peyronie's disease, or would it be something else?
Well, if there is a curvature I mentioned earlier, the congenital curvature. For instance, I saw 3 young men with core D today. Core D is the congenital curvature. Now, some young men might not be paying attention to their actions until they become more sexually mature, and all of a sudden they realize, wow, hey, there's a bend here, or there's a curve, and those curves can be downward, upward, or lateral. Most commonly with core D, congenital curvature, downward, and you would not feel a scar. And that's because the core D there's a disproportion of elasticity. In the case of the man who has a downward curvature, more elasticity on the top than the bottom, so it will curve down. That's treated differently. That does not get treated. There's no non-surgical treatment that requires surgery. But there's also men who have mild Peyronie's disease, or let's just say mild scarring, that they can't feel, but almost invariably, if they come in and we do that technique where we pull on the penis and then power along the shaft, you can find areas of scarring that may be responsible for it, and that may indeed be Peyronie's. That is just not something they can actually feel.
Yeah, I think that's important. And when you think about that, typically the Peyronie's would not often be a downward bend, whereas the core D would often be the downward bend. That's kind of how we see those. And you've had it your whole life because it is a genetic thing. And then I think too, and so oftentimes, even if they can't feel it, when you do the ultrasounds, the duplex ultrasounds, you can find those plaque areas and identify what's going on there a little better, even when they don't feel it.
Correct.
Excellent. Next question. This I thought was good as well. This participant said, how can I talk to my partner about this condition without feeling ashamed or afraid of rejection?
Well, I mean, again, as I said in the first slide, Peyronie's is both a physically and psychologically devastating disorder. I remember not so long ago, I had a young man fly in from Sydney, Australia. And he came in because he had a 5-degree curve.
Wow.
Nothing but a 5-degree curve, and he was ready to throw himself off a cliff.
Wow.
I mean, it's your penis. And so any change that occurs is not wanted and can be devastating. So how do you address it? Well, if you've got ones that you're concerned about in terms of your interaction with them and how that might be affecting you, I think you say, you have this disorder. It is a medical condition. It's probably a genetic condition, but there are treatments that can make one functional again. The hard part, though, is in men who get severe Peyronie's disease, even though we can make a man fairly reliably what I call, again, functionally straight, 20 degrees or less in any direction, regardless of how severe their curve is, they're not going to get back the penis that they used to have. And that's hard to get used to. It's hard to swallow. So some guys, I just have to repeat that the goal is to make you functional, and hopefully that will be satisfying and reassuring, but it's still devastating. And if it's devastating enough psychologically, then I do recommend that those patients see a sex therapist to discuss the issue, to help them cope better with something that has changed, because it's an appropriate response to be depressed and angry or upset about this. It's a certainly appropriate to feel that way, but
Mm.
we have to move on. And so how do we do that? And sometimes some help can, from a sex therapist, can make a world of difference.
Definitely, definitely. I would say so as well. And it's so interesting because I think what happens is just like your young man who came all that distance, that's a long way to come for that 5% curve. And people might be thinking, but this is remember, we're already so incredibly vulnerable when it comes to sex and thinking about anything that's remotely wrong with our bodies or might be different or might be make us feel shame. So I think the sex therapist is so, so important. And we've had different sex therapists. Actually, one of them we had on, Dr. Jordell, Christian Jordell, we did something together for healthcare providers about the psychological ramifications of Peyronie's disease and really dealing with that side of it. So we highly encourage people to go to see the sex therapist. And we have put before on here, and we do have a little banner, Vic, if you can pop it up, of SMSNA. That's the Sexual Medicine Society of North America. That's SMSNA. That's how you can find a provider in terms if you're in a different area. But people from all over the world come to see Dr. Levine, so you can certainly see him as well. And then also the American Association of Sexuality Educators, Counselors, and Therapists. That's how you can find somebody. I'm a sex counselor, but you'll see sex therapists in there to talk to as well. I think it's super, super important because it's a very vulnerable disease. Wow, you have done such an amazing job of giving so much great information. I really thank you. We're going to come back to that. We're going to do our little bit of a closing centering exercise as we always do. It is a lot of information to unpack, folks, and I know that sometimes that can be a little overwhelming. So let's take a minute like we do to breathe, to get ourselves centered back into where we need to be. So let's take a moment to ground ourselves before we close today's episode. Let's find a comfortable position. You can sit, you can stand, you can lie, whatever you feel most comfortable in and where you feel safe. And if you do feel safe, gently close your eyes if you can. Take a deep breath, and you're going to follow this pattern in through your nose and slowly exhale through your mouth. Let's do that 2 more times, in the nose, out the mouth, for about 4 counts each. So inhale calm. Exhale tension. Let it go, let it go, let it go. Inhale hope. Exhale fear. Let go of it. You're not alone. You are not defined by your diseases or the things that are going on with you or disorders. Now place one hand over your heart, one over your lower abdomen. Keep breathing in your nose and out your mouth. Gently remind yourself, my body deserves care. My experiences are valid and my disorders do not define me. Healing is possible. I am whole and I am enough. Breathe in. Let those words settle into your soul. When you're ready, begin to bring your awareness back to this space and around you. Thank you for joining us today, and remember, be kind to yourself and the people around you. We need more love and kindness in the world, and each of us has an opportunity to pour more love, more kindness into the world around us every day. So remember that as you go forth. I take this opportunity to thank my guest. Oh my gosh, Dr. Laurence Levine, what an awesome presentation. How much amazing evidence-based information you gave us on evaluation of Peyronie's, on all the treatment options. And I know sometimes people they want to cling to, it's difficult to be in our position because a lot of times what men walk in and want from us is just fix it and make it better and make it all right. We can't always give them that easily, but there are non-surgical ways. And then for years, there's been the gold standard of surgical correction for these different things. So I really, truly appreciate the excellent, excellent information you shared with our audience today. So thank you so much.
Thank you for the invitation.
And so, Vic, can you tell us what's coming up next week?
Incontinence doesn't just affect the body, it can also disrupt emotional connection and intimacy. In this deeply insightful episode, Dr. Jeffrey Albaugh sits down with expert Dr. Diane Newman to discuss how urinary incontinence impacts relationships and what can be done to restore confidence, connection, and intimacy. You'll learn about the physical and psychological effects of incontinence, real-world strategies for couples, and treatment options that can improve quality of life. With candid, compassionate advice from two leading voices in urology and sexual health, this conversation helps normalize the discussion and offers hope to anyone struggling with this challenging condition. Join us on July 15th at 7 p.m. Central Time to learn more.
All right, so next week it's incontinence, sex, and intimacy. But this week, I hope that each and every one of you feels you are not alone. You might have thought, no one else has this. I mean, we have seen it all. We've seen slight curvature. We've seen literally penises bent up like a boomerang or a corkscrew. You are not alone, and you are not defined by this problem and disorder. And I think the greatest thing you gave us, Dr. Levine, tonight is just really reminding us that there's hope, there's treatment, there's wonderful people. People come from all over the world to see you because of the amazing things you're able to provide and do to help them move forward towards sexual health. So thank you so much for all of your expertise, sharing it with us, and the wonderful, excellent work you do here at Rush in Chicago with patients.
Thank you again, Jeff. Thank you for what you do, and you keep the baton going and putting exposure and our experience and pushing back the frontiers. It's a tribute to you. Thank you so much.
Thank you, and thank you, listeners, for learning. I hope that you feel validated and that you know that there are things that can be done. And we wish you the best. Have a good one.